Welcome back to Clinical Communication. My name is Ben. I'm a specialist physio and clinical communication skills facilitator here in the UK. And today I'm speaking with my good friend Rob Tyer, who is not only a good friend, but also a former advanced practitioner and now senior lecturer at the University of Sunderland. On this episode, In this episode, we'll be discussing one of Rob's key interests, which is around Cauda Equina Syndrome. We'll be discussing around the communication with it. So, when to ask, how to set up, how to ask about the specific questions, how to safety net, and how to advise about someone potentially getting further support and investigation if needed. There's a lot of useful information here, and I hope you find it useful. If you do find it useful, then please do share it with others. Please do follow or subscribe. Thank you for listening, and I hope you enjoy it.
We don't want to go too long as a white belt to be accused of sandbagging if you were to go into tournaments, but I don't want to rush to blue belt because there's some terrifying blue belts out there.
Is it hard because your Taekwondo is the original one? Was it hard? Do you think it's harder going from a striking to a grappling martial art? Because for me, from going to judo to jiu-jitsu, it's basically just the judo groundwork of judo. It's not that hard. Was it harder, do you think, to go from a striking one to, I know you've done MMA as well.
Brief stint. I wouldn't say that I had any sort of accomplishments in that field at all. It was, like I say, brief stint, less than a year while at university. But yeah, so my striking background is a WTF Taekwondo, as in World Taekwondo Federation, not as in what the fuck Taekwondo. Although watching it now, I do utter what the fuck quite regularly, because it's changed massively. WTF Taekwondo, very little hands in terms of striking, all kicks. Body positioning is much more bladed, lots of up and down, bouncing in and out, sort of changing of distances. So to then transition into an art form where that bladed stance is quite dangerous for me to have, and to be up and down on my feet is not useful, and to have to be more square, to not use some of my sort of like eye movements to sort of read when people are moving, because they're not moving in the same way towards me as they would be if they were trying to kick me. So there is very little transferable skill in that regard, other than an affinity towards learning movements and positions. So I don't think it served me well in the way that some people might think it would have done. The thing it probably has served me well in is if I put you in my close guard, it's pretty strong, because I've just spent years developing leg muscles. So it's clamp down on you there. Not to say that nobody can break it, that's not at all, but it just, I feel safer. Like if I manage to get my leg wrapped around in a close guard or even a half guard, I feel a bit right. I've got time to breathe here. So yeah, that's probably the main transferable thing, is just development of legs.
Get across. I think it's the WTF, is that the Olympic one, or is that the not Olympic one?
That's the Olympic one. Yeah.
And it's changed because of the points?
It's always been points. So I mean, you've always been able to win by points or knockout in WTF, but it's driven more towards a spectator sport now, in my opinion.
Right.
Which means that it's largely points driven. So it went from, so this is really going to be the whole grumpy old man and get off my lawn type rant. Not so much this Olympics. It seemed to improve a bit this Olympics, but previously watching it felt like watching fencing without swords. So the electronic scoring was basically pushing people towards a front leg style, which is okay, but kind of front leg style to touch. So if you make contact, you've got sensors in your foot pad and your hand pad, sensors in the head guard, and sensors in the hogo, the body armor. And so touching those sensors would register a point. Now, back in my day, we didn't have the electronics in the same way. We had 3 corner judges and a referee, and you have to visibly you had to hit someone hard enough that you visibly moved their body.
Right. Okay.
And it took 2 out of 3 corner judges to press your colour within a certain time scale for you to get the points. So it really does go back to what you see on the internet forums of people going, oh, it's the old styles, the hard style, as in like hard from a power perspective. And I would say that has some merit. The current style lends itself to a little bit more, so people who are just more flexible and got better coordination of their legs than probably the people of my era. So there's definite pros and cons. There's definite skills that they have now that is being molded by the demands of the sport. But I just don't like it.
It's not as entertaining.
That's all I can say. I prefer the old way of, spraying several shades of excrement out of your opponent to visibly score the point.
Yeah. It just seems actually more like combat compared to just tapping for just points acquiring.
Yeah. In my opinion, and this is all I can say is just in my opinion.
Is that the collective opinion, do you think?
I think there's people of my generation who would share a similar opinion, and I think there are people who of a younger generation would tell me to just get over it. Times are changing, and that's fair. That's reasonable. Like they have that right to do so. But I will try not to gloat too much when it gets dropped as an Olympic sport in favor of something more exciting.
Is it going to?
I don't know. I think there's been the rumor mill would suggest that it won't last much longer, but we'll see. Okay. Like I say, some very talented athletes competing in the sport now. But just it's not the same sport as I liked, and that's okay. It's not meant for me.
No, we get I'm trying to think. We get a silver. Someone got a silver this Olympics.
We definitely got a silver, but again, I just didn't watch it that much. I'm not really a sports watcher, if I'm honest with you. I'm much rather doing than watching. So I tend not to watch a lot. The only things I tend to watch more frequently is like the mixed martial arts side of things. I will spend time sitting and watching that, but I don't sit and watch rugby, even though I like it and I've worked in it for nearly 10 years. I won't sit and watch boxing unless there's like a fight that I'm particularly interested in, but I won't watch the full event. I've just got other things I'd rather be doing.
Yeah, same. Well, mate, we should probably actually talk about what people have clicked on this to talk about.
Shame.
I know. Now, I've already done the introduction,
Okay.
and just for the clarity of everyone, today we're talking about the questions and the communication with Cauda Equina Syndrome. We are not going through the clinical reasoning of it or the whys and the do's. Rob has a book for that, which you can go and buy, and we'll put in the link at the end.
Which Tom Jessen has done a great job in being a science communicator of. I had minimal involvement in the physical writing of it. He has done the legwork. I just provided some input from experience and some editing help. But yeah, Tom's done an absolutely cracking job with that and other projects.
And that book is still available for people to buy?
Yes, you can't have mine. This is mine here.
That's your copy right there.
This is by the bedside.
Just in case. But so for all the reasoning and all that stuff, people can read that or go to other things you've done in the past and it'll be there. What was it about of interest? What was it about Cauda Equina Syndrome that made you have this big interest in it and eventually led to that book being written?
It was thrust upon me through what was happening at work. So it was around about 2018-ish when there was this palaver about bilateral leg pain being a brief addition to some guidelines on the diagnostic criteria, and then rapidly removed and scrubbed from the internet, never to be seen again, because it was just misinterpreted by a lot of people. And so that had a big impact on the organization that I was working in. And one of the GPs with special interests, gypsies we used to work with, had a big interest in that and put out like a paper, like a white paper sort of thing, a positional stance on it. That got quite a bit of interest from the wider social media community. Um, and basically, I was in a position where I was developing my team leader skills as an advanced practice physio. And so because of that, I kind of had to take charge of certain areas of development, and it just came from there. And I think I'd had a few. I was given the nickname earlier on as a bit of a red flag magnet because I'd had a few pretty unpleasant situations, like clinically, that it's come into my clinic as a relatively junior clinician, a couple of them being Cauda Equina Syndrome. And that broke the mold of you'll only ever see one in your career, because I was only a couple of years into my career and I'd seen two. So, yeah, so it can extend from there.
And these are two true Cauda Equina, like the length of the
Yeah, for
span.
surgical decompressions.
Wow. Because, yeah, as you say, most people, you hear the stat, isn't it? You may have seen one in your career or something like that.
But you might have missed a few more.
Yeah, yeah. I mean, so I can say that I've sent in my 10 years 7 people to A&E, all 0 have been true. So
That's okay.
yeah,
That's absolutely okay.
yeah.
That doesn't mean that they should never have gone to A&E.
Oh yeah, absolutely.
Just bear that in mind, and for other people listening, you know, it's a good thing to be wrong as long as you've had justification to send them.
Yeah, yeah, absolutely. I think the bigger people often stress about, this initial stress is, have they got it? And then it turns into, should I have referred them or should I have sent them? You know, and I think I guess the other guidelines are there to, yes, that's 90%, isn't it, that go to A&E aren't true Cauda Equina, but
More. It's a really rare condition, but it's not zero. And
no,
so it's a tricky one because it's one of the ones that will suck you into a defensive stance, like medical legal aid and defensive practice, which is not a great position to be in general. And I used to have the mantra of I'd rather be the mug that gets it wrong, but you're in the right place,
yeah,
than the mug who gets it wrong and you're in the wrong place. Now, on the surface of it, that's a pretty innocent statement. You could argue that that would drive defensive practice, and it probably could and probably did in a period of my career. But I'm not one to sort of get married to those ideas and mantras. I'm quite happy to kind of embrace new ways of practicing in the face of better practice. But it's just the best I had at that time. And I don't think we've got much better at the moment in terms of diagnostic ability, because at the minute the MRI is still the thing
yeah,
that we need.
yeah. Still has to be, yeah. And actually, they're removing things, right? Because the anal tone testing's not as recommended anymore. Is that
So
right?
I'll speak to you on a personal position on
Okay.
things like this rather than what is recommended. So this got me into a bit of an interesting conversation with a group of clinicians about it. You know, the Get It Right First Time pathway that talks about um, neurological examination as a must and things like that. Anal tone neurological examination has to be done. Who does that is another question. So by doing anal tone, saddle sensation, physical testing, reflex testing, myotomes, dermatomes, by doing any of those, which out of those would stop you from sending this patient to A&E? And the answer is none of them, because they may have normal reflexes, although some of the literature is saying that bilateral loss of Achilles is more commonly associated with Cauda Equina syndrome. The bulbocavernous reflex, I ain't doing that in a community setting. That's just not happening. Sensory testing, it's not unheard of for me to send someone to the toilets and get them to do it themselves. I, don't necessarily can't hide behind the previous excuse of, oh, I'm not competent to do saddle sensation checks, because it's a bit of skin,
Yeah.
and we do dermatomes. Well, what I normally would say is that in a period of time that I have to see this person and then see my next person, what are the things that are really going to matter? And if I have to, counsel someone through the process, go and get a chaperone, get it done, get them to get their clothes on, then send them and write my letter, for them to essentially go through exactly the same process when they arrive at A&E. I don't understand the logic. When the symptoms are the things that are driving my suspicion, not the physical examination findings. So that's just a point of personal reasoning. But there was a large meeting where there was a national agreement that sensation checks were within the remit of the primary care physio or the community physio. But I just go back to the original point. Like, okay, so you do it and it's normal. Do you stop thinking that this is Cauda Equina Syndrome when the data says that, you know, less than 50% of people with anal tone laxity have Cauda Equina Syndrome? Sorry, I don't think I've said that very well. What I mean is, people with Cauda Equina Syndrome, less than 50% of them have a decreased anal tone. That's what I meant to say. So it's less effective than just flipping a coin in your clinic.
If you're thinking about the specificity and sensitivity, it wouldn't, you know, if it has a 50% chance, you probably wouldn't be very reliable on it, would you?
No, and the digital rectal examination is got much better prognostic value than diagnostic value. So if you have Cauda Equina Syndrome and positive digital rectal examination findings, then the likelihood is you'll have higher degree of symptoms or longer lasting symptoms than if you didn't. But it doesn't diagnose it.
No. And obviously there's me saying 10 minutes ago we're not going to talk about reasoning, and here we are.
Yeah, sorry.
But I know obviously there's stages, isn't there, of Cauda Equina, and the tone one's towards the latter part, isn't it, right?
Yeah, so like, you know, you might call these things terminal signs if we were talking about red flags. These are the later stage, the later onset signs, rather than the more acute ones. So by that time, if someone's got flaccid anal tone, overflow incontinence of the bladder, they're pretty far on.
So let's say it doesn't have to be physio. This could be GP, chiro, any healthcare professional, and let's say Steve, who's 50, has come in to see them first time for his back and right leg pain. Before we get into the specifics of the questions, at what point, when during an assessment, let's say he's not going to bring it up, right? He's not expecting, it's not something he's going to raise himself. When during a subjective should we ask these questions?
As I'm shaking his hand before he sits down. No, I'm just joking. I had this conversation with the students this week. What day are we on? Friday. This week. It's not like, hello, my name's Rob. Nice to meet you. How's your bladder function? Like it's not a good way to build a therapeutic relationship. I don't like strict order to the subjective assessment, because the subjective assessment pro forma that we're used to seeing is in my mind there for early stage clinicians to make sure that things aren't missed. But actually, I find it's a hindrance to the conversation more than a help, because you'll often find people, sorry, I need you to tell me how bad this is out of 10. I don't want to know about your job at the moment. We'll get to that. And they will not move on from that, and it creates conflict within the dynamic of the conversation. And I think it actually really hurts the therapeutic relationship. It tells the person that despite you asking questions, you're not listening, you're not engaged, you're not invested in this conversation. So I can't give you an answer as to when, but what I would say is I wouldn't leave it right to the very end, and I wouldn't do it right at the beginning. Because Sod's Law dictates that, 25 minutes into your 30-minute appointment, you go, oh, by the way, I've got to ask you these questions. And they go, well, I'm glad you've asked that. And then another 20 minutes ensues of you trying to unpick the complexity. So it's not at the beginning, it's not at the end, it's somewhere in the middle. That is the best I can do for you.
Fine. Ideally where it comes naturally.
Generally, if it's not being steered towards at all by the person, you will have to interject at some point and say, look, these are some questions I need to ask. when faced with somebody who's got back pain. But they may start talking about like, and then I've been taking the codeine, which has caused me to be constipated. And you go, well, because you've brought that up, do you mind if we just talk a little bit about that in more detail? And then that naturally flows.
Exactly.
Probably not the right thing to say, naturally flows, but you understand what I mean.
Yeah. They I sometimes will pair it if it hasn't come up. I'll pair it with the past medical history because it kind
Hmm.
of flips. It goes with the kind of the tick box bit of it. Because a lot of time yes or no's and they can answer it. And that you kind of hinted at there the setup for it. So people have different ways of setting it up. Obviously, you don't just want to come in and go, as you said, hello, nice to meet you. How's your bladder function? Because it's not a great start.
Yeah.
And so it's coming. What's your setup for it?
What's my patter?
Yeah, what's your patter?
Yeah. As a side note, I'm putting patter in there because it's nice for you to have a bit more diversity in your accents on this podcast. The previous two guests are far too eloquent.
Far too south of the border.
Absolutely. And we have a phrase in the Northeast that patter was water, he'd be drowned. So if patter was water, he would drown. So basically, have your own style of asking this question. Don't try and mimic how someone else asks it because it comes across as inauthentic. And patients are really good at smelling inauthenticity. Like the clinician reeks of it if they're trying to play a role. If they just have an honest, open conversation, far, far better, in my opinion. So it's along the lines of there's a set of questions I need to ask people who've seen me with back pain. They're regarding the nerves that live in your back, and their job is to turn everything on from your belly button to your feet. So I'm trying to use non-clinical language, non-threatening language here. I'm giving them an indication with gestures from your belly button to your feet.
Yeah.
That includes your bladder, your bowel, the bits in between your legs and your legs. So I'm giving them that sort of like slow burner. This is the sort of conversation that I'd like to have because I've not gained your permission yet. Some of it might be a little bit embarrassing, but I don't want you to worry. It's very normal to find it difficult to talk about these things. But the main reason we ask them is because it changes the sort of options that are available to somebody with these things. Is it okay if we talk about that? And I've never had anyone say no.
Some people say like you normalize it essentially, like this is routine. We have to ask everyone. It's part of the process. Kind of.
Yes and no. I don't want it to be so routine that you're doing it as a going through the motions thing.
Okay.
I'm really sorry. It's something we have to do. It's not, I don't want you to come across in a way that the patient just then shuts off and just gives you that yes, no binary answer, because actually the question itself is useless without the second and third layer questions and the clarification points. And if you almost do it that way, you're turning away from the person essentially with a tick box and you're just going through this list and that person leaves the conversation.
Yeah.
Or doesn't feel part of the conversation because they could have given you that on a bit of paper before they came in the clinic. That could have been an entry questionnaire.
Yeah. Does that have interest? Are those more effective or less effective compared to just asking someone directly if they have it on a sheet of paper beforehand?
So they've been useful in the past when I've had issues from a communication perspective. So like English is not a language that a person has. So I've used the MACP translated versions with the translator and said, can you read this? Does this make sense? And that's given me some help. But as a performer, literally 2 minutes before coming into the waiting room, I don't see the value as a triaging mechanism. Very valuable.
Yep.
Because it brings it to the top of the list for your attention to then pick the phone up and ring someone.
Yeah. Okay.
But it's much like with research. So if I send you a survey, I'll get yes or no answers or very short answers because you're not going to want to spend ages typing on your phone. You're just not going to. Or if I have a questionnaire, an interview or a focus group as part of the research, I'm getting more depth. So like surveys, I'm getting more breadth. interviews, I'm getting more depth. And for this, I want depth, not breadth.
Yeah. So, and I'm just thinking of all the kind of newer graduates or even students potentially listening who will all ask the same thing and find it awkward at first. Apart from saying, which I would say, it gets easier with practice. Is there anything that you found that makes it feel a bit less awkward to ask for those earlier in their career?
No.
Uh, Fine.
You've just got to do it. I mean,
Yeah.
it is in my mind, and so this is something I get pushback on from certain people, is that it's a non-negotiable for every single person who comes in with back pain, regardless of whether there's leg pain or not. It's a non-negotiable in my opinion.
Mm.
Some people would say only in the presence of leg pain, and I understand the rationale. Some people would say I wouldn't do that because of the potential iatrogenic effects of your words. I would say the iatrogenic effects are minimal compared to the consequences of missing something, given you only need one of the many symptoms of Cauda Equina Syndrome.
Yeah.
For the new grad, you're just going to be embarrassed. That's
Yeah.
it. I mean, it's the whole like the acceptance model we're trying to get patients to understand when it comes to persistent pain. Unfortunately, we have to kind of rapidly go through those stages with a student clinician, like the pushback, the anger, that oh, it'll not apply to me. The eventually you've just got to accept it, and the
Yeah.
sooner you accept it, the better. Because you push it to one side or you put it off, it becomes a bigger problem.
Yeah. And you have to do it for for the right circumstances. So yeah,
Hmm.
fine. Right.
I don't like it as a matter of cause, if I'm honest with you, because I have seen referrals where patient reports 6 months of elbow pain, no Cauda Equina Syndrome. And you're like, yeah, this is not a good use of judicious questioning. This is
No. No, I think that's one of the things where as you gain experience, you learn what not to ask in a way, and things you don't need to do. And when you start out, you have your massive, as you say, that subjective template reminds you what to ask, and you kind of do it in order because you're learning the process, and then
yeah.
over time it dwindles down.
Because for some people, this is the first time they've articulated their problem verbally
Mm,
outside of their own thought process. So they're going to stumble over words. They're going to kind of, oh, and then this, while I remember it, I'm going to talk about this. So, like, if you interrupt that flow, they'll either not get out all the information or they'll shut down and go, well, nobody's interested in this. So, like, you just got to let people go within reason. You know, they start talking about, and then last week, my sister's dog walker did, like, okay, we need to bring this back into something a bit more reasonable for the clinical consult. Time is unfortunately a factor
yeah,
for the next person coming in. So you can't just let people go off for ages and ages, but sometimes you need to.
yeah, yeah. And you never know, they may feel what they're telling you is relevant, even if you can't see it or
Yeah.
know straight
So
away.
give them a chance to
Yeah,
tell you a little bit about their sister's dog walker
yeah,
and see where they're going with it.
yeah.
Like, because it may be just about round about the houses way of getting to a point.
Yes, there may be an easier way for them to get out the difficult thing they don't want to say potentially. Um, so if we go through the questions, so everyone always thinks obviously starts with bladder and bowels, and I
Yeah.
think the most classic way I hear people ask is um, any new or recent changes to your bladder or bowel function.
Hmm.
Um, and then you can go into more depth depending on what they say. Um, is that for the bladder and bowel? Is that a sufficient way to ask?
Probably, but it's not. It's not what I do. So
Okay, go on then.
it's not too dissimilar. But you just gotta like you've got to do a better job of what I'm not doing right now, and you've got to be clear. So um, things like new or recent are too nebulous
Mm, yeah.
because that that means different things to different people. So I want to be a little bit more tangible. I want to create a bit of a timeline.
Mm,
And if they can't answer it on the first go, I've at least started the thought process of these questions this guy wants to know about. He wants to know it like an order. So it gets them thinking a little bit more. So I normally start with along the lines of, since your back pain started, since
mm.
this back pain started, if you've had multiple episodes, has there been any, and then continue along that line.
Okay.
So from a bladder perspective, I don't chunk them together. I don't go any changes to your bowel or bladder, because the types of changes that manifest in the bowel and bladder are different types of changes. Some of them cross over, like on the Venn diagram, like frequency, ability to control it, that sort of thing. They cross over heavily. But there's other nuances, like the difference between incontinence and retention and constipation and stuff like that.
Yeah.
So I want to give each one due attention.
Okay. Bladder and then bowel. And obviously they may say no, they may say, well, I've had this stuff for a long time. They may say various answers.
Yeah.
And you can reason out, you then delve into it from there, and reason whatever's
Yeah, and usually people, they're quite open. Like this is again just in my observations. Like women tend to be quite happy to talk to you about bladder symptoms. Men tend to be quite happy to talk to you about bowel symptoms, and not the other way around as easily. So you sometimes need a little bit of teasing to get that information out of them. And there's another point I was going to raise there about the questioning. Yeah, so the answers would be sometimes, not really. So for me, this is a binary answer. It's a yes or a no answer. Not really is no good. And if you were being really harsh, it wasn't one of the options I gave you. So,
Okay.
and I don't say that, of course, but like, and so I would say something along the lines of, so not really or not at all, and let them have that space. So, rather than just jumping on the next one and almost just becoming a bit of a where were you in the night in question sort of interrogation, light shining in their face sort of thing. Like, keep it does have to be sort of a little bit more like a line of question, like an interrogation, but it doesn't have to be an interrogation.
Yeah.
So you have to kind of go, I appreciate what you're saying, but I'm not quite sure I understand and I'm able to answer the question
Yeah.
with the information you just given me. So what I need from you is this.
Yeah. Make sure you get the answer, but in a nice way,
Yeah.
so to speak.
Yeah.
They don't feel too forced to give an answer.
Absolutely. And it may be that you have to leave that question and come back to it. Like quickly, I would say come back to it. Don't leave it and go, I'll catch them before they go, because you won't. You'll forget.
Yeah. Yeah. So that's bladder and bowel. Everyone, people think about, and then after that, they think about then the sensation. And I still hear people ask at
Yeah.
times,
Yeah.
any change in sensation in your saddle area?
Yeah.
And I
So they
think,
go and rub their bike seat and go,
oh
no, this
God,
still feels like vinyl covered bike
I
seat.
know. And I've even heard Tom say this as well. And I think, what if I was not a healthcare person? What on earth would I understand or mean by a saddle area?
Yeah.
So, apart from those situations, most people say change in sensation when you wipe when you go into the toilet in your genitals or backside, um, or very inner. Sometimes people say inner thighs as well.
Yeah.
Um,
Which is right.
yeah,
That's the part of the skin that touches a horse's saddle.
yeah. Um, if they don't say the saddle bit and say the wiping bit, is that sufficient? For
Um,
most,
not always. So
okay,
most of the time, so it is sufficient when someone is definitively able to say yes or no.
okay,
It's not sufficient if they start scrunching their face up and looking in the top corner of their eye to try and think if that is the case. Like, if someone's got numbness, it's usually pretty obvious to them that they've got numbness,
mm,
like frank numbness.
mm,
If they haven't thought about, oh, I've not thought about that, it's probably not, if I'm honest, because it's not something that would be quite usual to tell. If you were to wipe your backside or wash your genitals, you would normally recognize that something is touching that area. It's a pretty sensitive area.
okay,
But if you're just relying on the whole wiping your bum sort of thing, you're limiting your ability to help coach your patient through giving you accurate information. So you need a few backups. You need something in your back pocket to give them alternative examples. So for me, it would be things like, um, if you sit in the bath, does the temperature of the water feel the same all the way around your legs?
mhm,
So if
okay,
you're sitting in a warm bath, it's going to be pretty evident that something feels off.
yeah, yeah, yeah,
Or if you're washing yourself in the shower, that sort of thing. The other thing would be if you use feminine hygiene products. So is there a noticeable difference in sensation when you're using those? Because the sensation is also, it's a hard thing for people to grasp, like to think three-dimensionally, but sensation is also an internal sensation thing.
Mm.
So that would be another cue or trick to help jog people's memory.
That's a good point. Do you think that helps then get into the from that sensation question, especially with the, I'm just thinking with the, I've never heard of the feminine hygiene product one before. Does that then help get into the altered sensation during intercourse or altered intercourse function?
Yeah.
Because I think people would probably find that the most awkward to ask of all
Yeah,
questions.
that's when the faces go really red.
Yeah. I think for
Um,
chaps asking about erectile dysfunction, especially for a certain age, it's not too
no,
bad.
and vice versa. When the dynamic in the room is this person is probably someone who understands the function of this part of the anatomy.
Yes. Yeah. Yeah.
That probably is an easier conversation than if there's a bit of a mismatch between the perceived dynamic and I'm mincing around my words here because we're in a very very interesting time where there is lots of other things going on
Mm.
socially.
Yeah.
But if we just break it down to pure anatomy,
Mm.
if you own that part of the anatomy, you usually understand what its normal function is. If you
Yeah.
don't,
Yeah.
then you rely heavily on the other person who does
Yeah.
to give you that information. And
Yeah.
so oftentimes that is the most tricky subject to navigate, not because of the social sensitivities, but because of the knowledge.
Mm.
And I don't mean to be too blunt, but we often get a bit of a laugh in the classroom because I normally break it down to the students and go, and for the guys in the room here, it may surprise you to know that women can have orgasms too. And so it's a bit of a like a an icebreaker. And what we're looking for is the inability to reach climax, regardless of what your climax is, the inability to reach it, because usually climax is a sensory driven thing. So it's normally the question is along the lines of, have you noticed any inability to reach climax or orgasm during sensation or penetrative sex? And the term penetrative sex is broad because
Yeah.
not just one half of the population have penetrative sex.
Yeah.
So it's an internal sensation thing. That's it. That's the top and bottom of it.
Yeah. Yeah. And actually, I think
And it would also be with someone or by yourself would be the other
exactly.
thing, because people often will say, "Well, I'm not sexually active at the moment." You might not be sexually active with somebody else, but you still might be sexually active by yourself.
Yeah. And I guess for some people, if they're in especially significant pain, that may not be on their mind.
That's usually what I would normally say is that I appreciate this is the last thing that you're probably wanting to do given the amount of pain you're in.
Yeah.
So the next question along those lines is usually from um, the other questions, like the feminine hygiene product side of things.
Yeah.
Like that's not a sexual thing, but it's a sensory thing.
Mm.
And then from an other perspective, it's like if you normally wake up with an erection, is that still happening?
Yeah.
Or not from a Cauda Equina perspective, but from a priapism perspective, um, if you'd lost the ability to have an erection because of age or medical health problems, are you now getting erections?
Mm.
Because that's not a good thing.
Ah, okay. Ah, okay. So it can go in reverse.
Yeah, but not from a Cauda Equina perspective. So I'm broadening it out here from a spinal pathology perspective.
Okay.
So priapism is not always, but it can be to do with a space occupying lesion of some description, usually a tumor, pressing on
Mm.
the nerves in the spinal canal.
Oh,
So
okay.
if you were of a certain age and erections are a thing of the past, or normally if you have a couple in the room, what the wife normally says is that's not worked for years. So
Yeah.
patients are often very blunt about stuff.
Yeah.
It can be quite hard not to crack up and have a bit of a laugh. Sometimes you can, and it's appropriate to do so. But um, if they then start getting an erection and it won't go away, the main thing is that it's not just a transient thing. It's like actually, they get an erection and it won't go away. That's something that needs to be checked
Mm.
urgently through A&E.
Yeah. Yeah. Interesting. They so yeah, the sometimes it's being, as you say, being direct in a nice way. Um, and I think that's why it's so important. You have to just you set up the questions, or ideally it comes up naturally and just build on it. Because you're not just going to say you know, bring them in, say hello, shake their hand, and say, you know, are you still achieving orgasms? The first
Yeah,
time meeting
yeah,
someone.
yeah. I mean, it would be a very good handshake if that was the case.
Well, yeah. And well, out of interest, just if they say, you know, the no or the I don't know, I haven't tried since my pain's come on, and they're not of the age, they can still get if if it's a chap, they can still get morning erections, for
Yeah,
example. Um, can we? Is there different ways to ask that question if they haven't tried?
yeah, it's a tricky one. Like I said to you about sending people to the bathroom to do a sensory check on themselves, I must admit I've never sent someone to the bathroom to check other functions
Yeah,
like that. Um, that probably is a line that I just haven't crossed,
no,
and I normally try and navigate that verbally, um, using everyday language that they might use. There's a few choice words that I'll probably leave off the podcast, but like they will volunteer the language, and you
yeah,
kind of it's okay to echo that and
yeah,
demonstrate that active listening. But the clues would be if someone's getting sexual dysfunction, then the likelihood is it's a sensory driven thing.
mm,
So you can get away, maybe. I don't know for sure, but I would certainly say I feel like I could get away with the whole go and check the sensation side of things.
yeah,
So it's not necessarily a motor thing.
mm,
Um, in the early stages, of course, spinal nerve compression can manifest as a motor thing. Of course, it can. But in terms of the early stages, I think it's something that I would say navigate it down via a sensory thing.
and then we get to the elusive and very randomly worded terms about gait and control. And some people will say, you know, how's your balance? Can you still control your legs? And I mean, I'm sure you've seen it as well. Tons of people with sciatica who limp or
Yeah,
a bit more unstable. And I realized that the gait and the foot drop and all that's kind of on a side to the rest of the symptoms.
yeah,
It often gets asked with it.
yeah. I bundle it in because I'm not just having a Cauda Equina conversation. I'm having a spinal red flag conversation, and equally, it's not always about identifying the red flags. It's a signpost and opportunity for things that cause erectile dysfunction that are nothing to do with the spine, or
Yeah,
things that cause pelvic pain during intercourse that are nothing to do with the spine. It's a signpost and opportunity.
is simply saying, have you, since your back pain's come on, are you noticing more unsteady on your feet? Or I often ask about, are you noticing, of people ask about weakness?
Yeah.
Um, I think a drop foot's fairly obvious. People would hopefully see if they've got a drop foot and probably wouldn't
Although I
say.
did have a referral from someone saying partial drop foot, which I'm not quite sure how you have a partial drop foot. It's either dropped or it ain't. So
Some of the time.
yeah, yeah, intermittent. Well, to be fair, you can get an intermittent one for a variety of reasons, but like it's either dropped or it isn't.
Can we, is there like, obviously, as you say, you're being more direct with the bladder and bowels and the sensation and that side of things. Uh, do we need to be direct with the foot drop and the balance, or can that be more, a bit more vague?
Yeah, I think so. With foot drop, with balance, it's a tricky one because patients, people, service users, I don't like that term personally, but whatever you
Yeah,
call the people who come into your clinic, generally they want to try and please you by giving you helpful information. Like they're not trying to be obstructive. If they don't know the answer, they don't know the answer. So if you feed them with a leading question, in my mind, any changes to your balance, you could argue that's the same for the bladder, but that's a really important thing that I want to know about.
mm,
Any changes to your balance is probably an okay way to ask it because it's what you do with the information next that's important.
mm,
Oh yeah, I mean, I'm bumping into things a little bit when I'm walking around the house, and because so your second layer questions, the important thing, was that a significant increase? Have you never bumped into anything in your house and now you're always bumping into something in your house? Or is it like, well, no, it's just because you've asked us, I'm bringing it up. With the foot drop side of things, it's catching your toes on the step or tripping over on the carpet. I do that every now and again. That's just because I'm not paying attention.
Yeah.
But I'm talking about a consistent thing. So it's not like it goes away and comes back. It's like a consistent, and if anything, a progressing thing, like it's getting worse.
Yeah.
That's the key thing here, is what's the trajectory of the symptoms? Like, is it stable? Is it rapidly getting worse, or is it intermittent?
Yeah. I forgot to say, with the sensation, obviously you also ask about the sensation when you're opening your bladder or bowels. Would you pair that with the function, or is that a separate question with after the sensation, or
Yeah,
does
I
it
think
matter?
it's a nice little blender. Like, it goes from one question, helps you sort of transition to the next question. So like when you do ask about the bladder function, it's not just about the ability to make your bladder or bowel function, but also the urge, the
Mm.
sensation, and then you move on to the sensation potentially. So
Yeah.
there's no order really, other than what you're comfortable doing. I would recommend that you develop an order so that you minimize the chance of missing a part of your questioning.
Yeah.
But ultimately, don't hold people's feet to the fire if they want to start telling you about their bowel function because you've mentioned the word bladder.
Yeah.
Let them go,
Yeah.
and then come back to it.
I think any of the Cauda Equina questions I've missed.
So we've covered, to a degree, bladder, and obviously there's much more nuance there with that
Yeah.
conversation in terms of frequency and urge. Like, are you getting an urge or not? Bowel, the difference between constipation versus motor loss to defecate. That's a key one. Like,
Cool.
people will often say, well, since I've been on the codeine, or I have been constipated, but it's really important to delineate between
Yeah.
what is, I have muscular control and can squeeze, but now it's coming out, versus I do not have the ability to squeeze.
Mm.
They're two different things, but some people from the public, might label it as constipation because they don't know any better.
Mm.
So that would be the only thing I would say, is that yes, we've covered the questions, but there's depth, there's angles to go at it from. And this is not like with every single person, because there'll be people listening going, do you speak about anything else other than Cauda Equina symptoms in a consultation? Yes, yeah, definitely. But it takes up a bigger part of the assessment if someone says yes or is unclear.
Yeah.
And equally, when I was working more frequently in a clinical environment, the funnel of patients were the people who are seeing me, because it's an advanced practice clinic,
Yeah.
are likely going to say yes more than the people who are seeing the primary care first line treatment. Um, that's just the nature of how the system works.
Yeah. And we have it in the pain clinic as well. Our nature of our patients, they don't just have pain, they have multiple other issues as well. And they will
Yeah,
say yes to half of them. But in reality, and most of the time, it's a long-term thing that hasn't changed recently and has a diagnosis behind it, or there's a reason potentially.
yeah,
I just remember, I've like we said earlier, as years go by, your kind of threshold for panicking gets higher, because you kind of learn what
yes.
what they can say, what's not so scary. You go to your senior all the time to say, oh, it's okay, don't worry about that, or it's because of this, and blah 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 blah.
You just
Uh,
fine tune, and I'm going to trademark this, and the students know about it. It's called Rob Tyer patent pending oh shit meter.
okay.
And so when someone gives you an answer, what
Yeah,
does that do to your oh shit meter? Does it go up, or does
yeah,
it go down to the phew? It's like, where is it?
yeah,
And someone says something, do you have pain at night time? Yes. Oh shit meter goes up depending on your level of um, work in that environment.
yeah,
And someone then, with further prompting, will tell you that it's when I roll over, it hurts. When I roll back over, I can go back to sleep. Versus, it doesn't matter what position I'm in, I'm out of bed, I'm pacing, I can't settle down for half an hour, I've got to take medication.
yeah,
Both of which technically red flags, because they are yes to the night pain box, but very, very different
yeah,
presentations.
yeah. Absolutely, definitely,
And
definitely.
that's the second and third layer stuff
Yeah,
that's more important. So, like, the first question is an introduction or an invitation to a conversation about a topic.
yeah,
Second and third is your clarification points. They're the most valuable.
Yeah. So we go through the questions. Let's say Steve, like how many 90% odd people plus doesn't have anything that concerns you. But people do this, obviously talk about the safety net. And Steve has back and leg pain. And sometimes the safety net is just, there's the card, right? Here's the card with the information on it. If you ever, those questions I've just asked you, if you ever develop any of those symptoms and your pain's got worse, take this card to A&E, go tell them. Which I think is, I guess you're covering your ass, but you haven't told them why. And that can still leave a bit of, as you say, panic, fear, uncertainty, maybe is the best word to phrase it. From what you, again, from experience from reading, what do you suggest is the best way we safety net for people that aren't saying anything that's making us worried?
It makes me laugh a bit because it goes back to, I don't know when this is going out, but it goes back to your Instagram post yesterday about, provided empathy. I've empathized is not the same thing as I've provided empathy. And I often see in notes is, I have safety netted the patient. Yeah. So kind of like I've done this thing to them,
Yes.
which doesn't necessarily suggest that it's been a conversation and therefore the person who needs to understand has left with an understanding.
Yeah.
They've just had information thrown at them.
Yeah.
And that's not good practice, like just having volumes of information thrown at you. So it depends on what medium this person has access to. So if they have digital access or they prefer the good old-fashioned analog side of things. On a bit of a tangent, I don't have a problem with giving people leaflets if that's what they want and that's what they need and that's what the situation calls for. But if it's my issue with blanket application of here, take this, and not necessarily explaining it, like you say, to understand it. I think the key thing is to get somebody to understand what to do and when to do it, but also the likelihood of them ever having to do that. So this is rare, very rare. In fact, statistically so rare that me right now with no back pain is as likely to get Cauda Equina Syndrome tonight as you are with back pain. Like there is no predictive value of, like, for example, I don't have back pain. That doesn't mean I don't have a disc bulge right now. That doesn't mean that the tail end of this cold that I'm getting over, I roll over in bed and sneeze. That doesn't mean that I'm not going to get Cauda Equina Syndrome tonight, but it's super, super rare.
Yeah.
So the key is, like, look, I'm bombarding you with all this information. I know it sounds scary, but it's unlikely to occur.
Yeah.
So rather than you having to memorize, because I'm having to spend ages with students to help them learn it, and as a clinician, I've had to spend years refining my knowledge in this area. Why do I expect you after 20 minutes to recall all the intricacies of all these 5 sections of questioning?
Yeah.
Again, say to the students, I'm not looking at your factual recall knowledge. I'm looking at your understanding and your problem solving ability. And you've got the entirety of the world's information in the palm of your hand.
Yeah.
So all I need you to know is, if there's something that you think ain't right, where's the information I need to remind myself of what to do? Because you can take 20 minutes. You don't have to pick up and ring 999 at the mere inkling of something changing. Like, look for the information that you were given. So here's the information, whether it be analog or digital. Keep that somewhere safe. If you feel like you are unable to speak to somebody, it's like 9 o'clock at night on a Friday, no GP surgeries open, physio services shut.
Yeah.
Where do you find your information? Well, here it is. Let's have a read through it. Is that information written to a level that you don't need 3 degrees to understand? Because that's the other important thing as well. Like, you can have saddle, Cauda Equina, nerve roots, all that stuff. It means nothing. Basically, the credit cards that the MACP put together with Sue were tremendous. Really, really good use of resource, because particularly when they were translated. the next level stuff for me was when they really put together something super useful, was the video of when to seek urgent care with back pain, because it's verbal and there's pictures of people pointing to areas, which is far more useful than just having to interpret language on a bit of paper.
Yeah.
So that would be my safety netting process. Like, I have safety netted you with this because I've given you this information. My sort of practice would be along the lines of, here's some information we can give you, paper, digital, whatever. Put it somewhere safe, keep it somewhere safe. And if you have a question, look at it. If it doesn't answer your question, then you need to speak to somebody. And depending on the time of day or access you have, that might be a phone call. It might be, unfortunately, turning up to A&E, even if it's inappropriate.
Yeah.
But we want to minimise that.
Yeah. Just because otherwise, you don't want to. You can have to tell them other things as well about what's going on and the treatment suggestions and all that jazz. That's just going to add to other things they have to try and remember if you don't give them something to. And I think a leaflet in this case is fine. Yeah.
I'd say so.
I think
as long as it's well written.
Yeah, easy, and it's just quick, rather. And I think for situations like this, it's all right. I have interest. I obviously see people with long-term pain who've had scans and all their blah 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 stuff done. I will often tell them that if it was going to happen, it probably would have happened by now. And we're talking 6 months, a year down the line, at least, probably, or maybe even 10 years. Because it often is very acute. Is that right?
Sort of.
Okay.
Sort of. Because you probably have a wide demographic of all ages in your service. Would that be fair?
Yep.
It's not just like 20 to 40-year-olds.
Yeah.
It's, adult. What is it, like an adult service, 18-year-olds and above?
18 to however old. Yeah.
However old. So your acute onset is more likely to be discogenic in origin, which therefore would lend itself to a certain age demographic more so than another, not definitively. So you're younger, which I'm still technically a part of, more likely to be disc bulge, herniation, sequestration. However, you've got your slow burners, which are your people who have so it depends on how well you pick your parents. Again, your genetic predisposition to canal size, like how big your spinal canal diameter is largely genetically driven. But then things take up space. So age-related changes, normal narrowing of the canal, and maybe degeneration of discs, which cause widening of vertebral bodies and movement of disc material, and the invisible stuff, the inflammatory stuff, so the chemical process plus the pressure exerted through fluid. So if there's extra inflammation, so all these things, like almost like the stars have to align a little bit. You get this sort of slow burning Cauda Equina compression, which is often the difficult one to delineate when you're in clinical practice, because if someone is of a certain age, they have a higher likelihood of having stenosis, and therefore they probably won't have a rapid onset Cauda Equina episode. They'll probably have a slow burner and then a tipping point, and it'll be obvious that something's manifested now. So half of what you said I would agree with for certain populations, but for the older population, I wouldn't necessarily. I wouldn't be reassured by the fact that it hasn't happened yet.
Okay. Yeah, I think you're right for the stenosis ones. And again, this is where I'm blessed with all of ours have had imaging, and we can, you said about canal size and stuff like that. You can kind of see, stenosis ones. And we do get the ones where they're just not suitable surgically wise for whatever reason.
Yeah.
And then, yes, as you say,
well, this is it. Like, at a certain age, people may be happy, and I'm not generalizing here. I'm just saying that in my experience of having conversations, some people may be happy with having some bladder inconvenience rather than spinal surgery, because that's all their symptoms are at that time. It's not the same sort of bladder disturbance that we hear about when we're talking about these acute disc presentations. Some people are happy to put up with some level of saddle numbness rather than having the surgery. But if things were to change, that this is the key thing, is that if things were to change, that doesn't mean you can't change your mind. If something acutely deteriorates, we have the ability to revisit the drawing board, and those options become options to discuss again. Obviously, if the risk of going on the table outweighs the risk of the symptoms of Cauda Equina from stenotic compression, well, then a surgeon will probably counsel you out of having that surgery for obvious reasons. The other thing I would say is that, and again, I don't want to go down the whole defensive practice and fear-mongering and iatrogenics and all that stuff, but an MRI scan is not reassuring for future. It's just reassuring for now. So when you had that MRI scan, you did not have Cauda Equina compression. That does not mean that you won't get it. And this is not me saying you need to tell people and counsel them, because God will have people leaving departments nervous wrecks. But in your mind, you shouldn't talk yourself out of a risk. So for example, I'll give you a clinical scenario that's happened a few times, where someone comes into clinic with worsening back pain or worsening neurology, and they'd been to A&E a month ago, and the MRI was clear for Cauda Equina compression, but their symptoms weren't the same a month ago. They've progressed. So that MRI almost becomes mute. I'm not interested. I am, but if you catch what I mean, it's not definitive, and it shouldn't stop you from acting appropriately going forwards. The other thing that you might get from that MRI, I never got images as part of my job role. I just got reports, and I don't want the images, if I'm honest with you, because I don't understand how to read them. So what we'd be looking for is someone's report commented on the fact that there is no Cauda Equina compression, but there is a bloody great big disc swelling causing canal narrowing. We've still got cerebrospinal fluid going through. There's been no signal change or whatever if it was in the cervical spine. But they had something that could have potentially, wouldn't have taken much to progress. So they didn't have Cauda Equina compression, but it's not unreasonable if that person then went to pick up something in the garden and chucked it over the garden fence or whatever, and something was to happen. That's not unreasonable to link those two things together as a progression. But if someone had similar symptoms and their MRI was like, pristine or whatever we want to call it, no canal narrowing, no disc bulge, nothing, it just bloody hurts, which is reasonable as well. Doesn't mean there's nothing wrong with you, it just means there's no surgical target. And it can still hurt a lot. But I'd be less inclined to think, without a mechanism of sudden onset, that this person has gone from having no disc bulge, patent canal, to whopping great big disc bulge and compressed Cauda Equina. The key being the history, how did it start? Has this been a slow burn or a rapid onset? So there's obviously nuance with this. I'm not trying to paint it as a black and white picture, because it isn't.
No, of course not.
But we've gone down the rabbit hole of the clinical reasoning again, haven't we?
It's fine. But let's say Steve does say that, actually, in the past 5 days, my not being able to hold in my urine as much as I was able to, and I'm feeling some numbness around my left testicle and left side in the thigh. And then you ask questions and you can't see there's nothing else that would explain this, and it's acute. And you reason that he needs to go to A&E. How should we have that conversation with the person in front of them? Us.
With care, but very directly. Like, don't mince your words. You're not there to try and reassure them so much that they don't go to A&E, but you are also, it's your job to deliver the information. And at the moment, what I'd say to someone like this individual would be, given what you've told me, I cannot understand, or I cannot rationale a reason other than Cauda Equina syndrome right now that you have these symptoms. or I might word it along the lines of, which would probably be better, is at the moment I cannot exclude Cauda Equina Syndrome as a reason why you have these symptoms. So what we need is for you to be examined by the people who can exclude that. And what I've not said there is, I need you to go to A&E for an MRI scan. That's not what I've said.
Okay.
In my head, that's what I'd like.
Yeah, yeah.
But that's not what I've said. Because first and foremost, they might see someone who has more expertise in this condition than you, or other reasons why they have the symptoms they have. And if they have a stronger clinical reasoning with a good rationale, then okay. I'm not suggesting that it's a hierarchy thing and you bow down in deference to a medic versus a physio, because you may see a junior medic who's just rotated to A&E and doesn't have much exposure to this stuff, versus you might see a consultant who's on call. You know, they're two different levels of clinician. The other thing might be you ring them up the next day, because you absolutely should have safeguards in place to speak to the person to find out what the outcome is. And let's say they haven't had an MRI. Don't go in kicking doors down and going, why the hell haven't you scanned this guy's back? It may be that they haven't scanned him because he doesn't meet the threshold to be scanned now, but the plan is to bring him back in the morning as an outpatient or in a day or two. And that rationale has been made in conversation with a neurosurgeon or a spinal consultant. And if that's the case, then that's their decision to make.
Yeah.
But I haven't answered your question yet on how I get them there in the first place.
Right.
So it is along the lines of, at the moment, with what you've told me, I cannot confidently exclude Cauda Equina Syndrome as a cause. Yes, it's still very rare, and the likelihood is it probably isn't. But at the moment, what we need to do to make sure you are safely and appropriately looked after is we need to get you into the system that can do that. And right now, me in the community, I can't do that.
Yeah.
Or I can't do that quick enough for you. So I could send you for a scan, but it won't be very quick. And this is a time-sensitive condition. If they were to provide pushback, which I think maybe is where you're going with this, as to I don't want to go, because that does happen. I've got childcare, I've got work, I've got lots of other things. You have to establish that this person has adequate understanding of the consequences of their decision, because it's their decision as to whether they go or not.
Yeah.
And this is not a life-threatening condition, but it is a quality of life-threatening condition.
Yeah.
And if we don't get you treated appropriately in a timely manner, you are looking at a life with symptoms of some description, of some degree. Yes, there are cases of people 5, 6, 7 years down the line who regain most of the function, but I mean, they're not the norm. That's outside of the trend. And the longer we leave it, the more chances you won't make 100% recovery. And it is up to them ultimately. And if they refuse to go, then we've been encouraged in the past, and I agree with it, that you document this very clearly. Long conversation had, talking about the risks, talking about the consequences. Despite this, Mr. Such and Such has decided that they're not going to go today.
I think that's, fair enough. And I think that's what most trusts would say, as long as you need to document it and that the risks, and it needs to be an informed decision, doesn't it?
You can't force anyone to do anything. And, to take it to its nth degree of extreme, if someone is told they have cancer, they don't have to have any treatment.
No.
If they don't want it, that's their decision to make, as long as they've been adequately counseled about the risks and the benefits, the pros and the cons, etc. It's their decision to make.
I mean, obviously, I think most do eventually go to A&E.
Very, very few don't. In the contacts I've had, some are hesitant and reluctant. Some are scared. It's important to tell them what the likelihood is that they're going to be exposed to when they go. So, an examination, an intimate examination. They may decide to do investigations that might include bloods, ultrasound scan, MRI scan, X-rays. It's entirely up to the clinical reason of the person that you see. But yeah, very, very few don't go. even if they're not happy to go. Like, yeah, I've had a few people like really, oh God, I've got to go. Well, yes, I'd like you to. It is important that we get this checked.
Yeah. I think you just said that key thing. Don't tell them I'm sending you to A&E to get an MRI. Because, yes.
Well, that's the pushback I get normally from people who say you shouldn't have these conversations with people who don't have leg pain, because it might encourage people to game the system.
Okay.
Oh, if I go to A&E and tell them I have this, this, and this, I'll get a scan. I think that's a really unflattering opinion of the general public that these people have. But that's not me being naive to say that that's never ever happened. I very much doubt that that's the case. I'm sure it has happened, but from a cost benefit analysis, I think that that's much lower likelihood than the amount of times I have that conversation with someone who then won't go off and do that.
Yeah. Yeah. And then obviously, as you say, they'll go off, they'll have whatever happens in A&E or minor injuries wherever they go, and then you follow it up
Well,
afterwards.
it should be somewhere that has access to an MRI scanner, either within the time that you're sending them,
Yeah.
or ideally round the clock.
Yeah. Yeah. And before we get into your hardest conversation, was there anything else about Cauda Equina conversations that you wanted to raise or that I've missed?
Maybe, but I can't think of anything that springs to mind. In situations like this, when we have conversations on a platform like this, I find it quite hard to get across certain things that other people might want to have heard.
Yeah.
Because I'm not prepared for an interview like this, other than I'm answering your questions to the best of my ability in a snapshot time. I don't, when you asked me to come on, I haven't then spent hours and hours and hours digging through the literature again and rereading the book and stuff to make sure I'm fully prepared. Because again, I don't think that's authentic. I think, we're just having a conversation here. So for anybody who is a bit unhappy that I haven't covered some things, I'm sorry, but yeah, I'm sure the information exists out there somewhere.
Well, there's a good book about it. People can
There is a book about it. Good is up to you guys to make that
isn't
judgment about
it? So, which leads me to ask, you knew I was going to ask this and ask everyone. I think you were making notes earlier. What is the hardest conversation you've had with someone?
I don't have a hardest conversation. I have memories of hard conversations,
Okay.
and I find them hard to rank.
Okay.
Having this conversation, like Cauda Equina conversations with someone that you have like some sort of regular relationship with beyond a patient contact. Like, for example, my mum's rang up with back pain. You have to ask those questions. If I live by the sword, I've got to die by the sword as well. So if I say you have to ask everybody, it's a non-negotiable. I have to ask everybody, it's a non-negotiable. So having that conversation with your mum is not a very easy thing to do. But it has to be done in that scenario. Difficulty like getting points across through interpreters, that's challenging, because there are cultural differences, there's language differences, there's things like metaphor that don't translate. And then some people have interpreters who will translate verbatim and it doesn't make sense. Some people will have translators who will interpret what you're saying and then translate, and that sometimes misses the nuance. So they are challenging conversations in general, supported by the resources I mentioned earlier, like the credit card, Cauda Equina leaflets. And actually, when some students have come to have conversations with me about this topic, so just from a Cauda Equina perspective, they're examples of challenging conversations. There have been times, I don't want to sort of give too much detail, but there have been times when these conversations have been had in clinical practice and it ends up unearthing some unpleasant information that this person's experienced.
Yeah.
And so then, you've unearthed it, you've got to deal with it.
Yeah.
In an appropriate manner, so within your scope of practice, of course. And I think what a conversation that people tell me they or suggest to me that should have been a hard conversation, but actually I don't think it was. It wasn't nice, but it wasn't hard. Was during COVID when my dad was poorly,
Okay.
and um, he's had a chest problem and vascular problems, so we didn't see him that often given the circumstances. Didn't want to give him any lurgy. Um, and when I saw him just before a Christmas, the first words that came out of our mouth is that you look like you're dying. Have you been to the GP? And he hasn't. And then eventually got him in there, and one thing after another, and within 6 weeks was dead and had widespread metastases. Given his lifestyle, it was not unexpected, but he didn't have a pre-existing condition that would have made us think, oh, this, he's got cancer, blah blah blah, right now. But it was one of those ones where you see someone and you go, and this is what we try to get to the students, is you don't need to have a medical degree or any sort of physio degree to recognize when someone looks like shit.
Yeah.
We as a species recognize when someone's poorly because we don't want to be around and catch anything. So it's a pretty good defense mechanism. So you see someone and they look grim, you have like this gut feeling that you need to explore. So that was a somewhat of a challenging conversation to get him to go to get and seek medical help. But yeah, lots and lots of challenging conversations. I've had to have these conversations from a Cauda Equina perspective when I worked in a high school, because I was working my high school sport. So having those conversations with teenagers, quite challenging. Having these conversations with people who either have cognitive difficulties through dementia or Alzheimer's, particularly the safety net side of things, and even things like having conversations with people who have learning difficulties, that can be quite challenging. And actually, I mean, it's good challenging because it highlights the over complexity of the language that you use, that you maybe don't realize how complex it is, and you really have to refine and again do a better job of what I'm not doing right now and being clear.
Yeah.
So there's some examples of challenging conversations. I do remember one that springs to mind now actually was the first time I ever heard the term manual evacuation. And that was when someone's bowel wasn't working and they had to, Ronseal tile, they had to manually evacuate their bowel using their finger. And I heard that when I was a student, I was a new grad on a neuro ward, and I'd never come across that after that. But then when somebody told me, when I asked them about bowel function, they got very upset and say that for the last few days they've had to didn't use the word manually evacuate. They've had to manually help themselves pass stool, and that was challenging in the sense of that took a lot for them to bring that up because they'd never told anyone that. They got quite emotional about it, and dealing with the Cauda Equina type concerns was a walk in the park by comparison to sort of the emotional fallout that can come from some of these questions. That they are probably the most challenging.
Yeah. Were you the first person to speak to them about the problem that they were seeing you for? Or do you think there was something about your conversation that then brought this up? Or was just the timing of it that it's just...
It's tricky to know because obviously I'm not in the room with the people who they've seen previously. My concern would be is if some people are going through this process in a tick box manner and the person's not necessarily felt like they're able to give that information because the person asking is not that bothered. I'd be really, really unhappy if it hadn't been asked at all. But again, not naive enough to think that hasn't been the case, because particularly if they're in a time pressure environment and they're at a GP surgery and this is the third of 4 conditions they're trying to tell a GP about in 10 minutes, it's totally understandable. I'm not trying to bash anyone or blame anyone. It's just, it happens, unfortunately. Or it could have been that that person has asked the questions really well. The patient wasn't ready to answer it. And because I'm the second or third person to have that conversation, something in their brains went, why is everyone banging on about this? This must be really important. And so maybe I should tell them. I don't know the answer, but those are my thought processes as to why that might have been, right time, right place, right person for them to volunteer that.
Yeah. Well, but thank you for sharing though, because I think it's important what people, I think you won't be the only person who's finds, especially as you said, whether it's the languages, whether it's the cognitive ability, whether it's a learning disability, whatever it is, that makes something already potentially difficult even more difficult. And it
You
affects
can only
everything.
do the best you can do.
Yeah, yeah.
And
Work with what you
it
can.
goes back to the get it right first time guidelines. I jokingly say I don't like the title "Get It Right First Time." I'd much prefer them to be called "Get It Wrong Less Often." But
Yeah.
Gulo doesn't sound as good as Girft, so it doesn't. It's not going to be adopted. But like that's all we can really hope to strive for, is just be less rubbish
Yeah,
as we progress.
yeah. The languages, especially, I remember there was of the seven that I've sent, one of them was someone who spoke a different language. And now looking back on it, whether it was their understanding, whether it was how the interpreter asked it, who knows? Looking back on it now, I think it was probably, and it wasn't Cauda Equina Syndrome. They said the answers that was the right, that meant they should have gone to A&E in theory, but whether it was,
Interestingly, on that, I did remember 'cause I worked in a part of the region that has quite a high Eastern European population, so I would often have interpreters from that end of the world. And I had a conversation with one of the interpreters. The patient hadn't turned up, and I got to know the same interpreters time and time again. And I'd say to them, "I've noticed something. Can you please tell me if I'm misattributing this, or is there a cultural thing going on here?" But when you ask someone, "Do they have pain here? Do they have pain here?" The answer is always yes, always. And I don't know why. And she explained it to me. She said that culturally, where she was from in Poland, she feels like there is not as much nuanced language to say it hurts a little bit, or it aches a bit, or it does this, or it tingles. It either does or it doesn't. So it hurts or it doesn't hurt.
hmm,
And so if I ask you, "Does your elbow hurt?" and you think, "Well, yeah, it did hurt a little bit this morning," well, the answer is yes.
hmm,
So the nuance side of things was lacking in that
hmm,
scenario, and I do wonder whether that is the case sometimes when having this challenging conversation that heavily relies on nuance.
yeah. Any way around it apart from being, I think the translation cards help a bit because you can
Yeah,
use that and be specific. But any other ways you found that helps?
but just it's case by case really, and sort of rather than it becoming you driving the questioning from a closed questioning fashion, like you know changes the frequency, change this, that they become a bit yes or no. Then the whole open question side of thing, tell me about a time when. Can you
Yeah.
give me an example of when that has happened? And then go from that to sort of
Mm,
like not judge the the sort of the accuracy of the history, but kind of get an idea of what they think constitutes a yes answer to your question.
yeah. Yeah. Um, well, there we go. And as you say, they're all difficult scenarios. And as you said, I said earlier, it can affect anyone, but not even just physios, but GPs, whatever clinician you are. And as you say, it can be very nuanced, can be very specific depending on the um, person in front of you. I'll end this on a slightly nicer question because obviously we set out the book earlier.
But the
And
harder question probably has to go on the list, doesn't it? Now, the Mount Rushmore of wrestling, that's got to be the hardest conversation.
well, that will come out a bit later. Um, so the last question is: you've obviously got this book out, which we can put a link to and people can read. What do you wish you knew that you now know about writing a book that you wish you knew before you started it with Tom?
So again, all credit has to go to Tom about the legwork. So I can't say that I have written a book because
Okay,
Tom did the writing.
okay,
Um, the process was long.
right.
So almost a year, Tom had moved to America. For almost a year, Tom and I had like weekly, fortnightly Zoom chats where we just spoke about the topic. Tom made notes, he sent them to me, we reviewed them together, we had a look, and we sort of like trimmed it down to like what we think we would want to have heard as a developing, well, not even just a developing clinician, but largely a developing clinician. Because the way we came at it was, if it's barn door concerning or barn door not concerning, that's easy. But your clinic is usually full of the vague and the grey. So what do you do when it's vague and grey? Well, you do the best you can, really.
Mm.
And it's okay to be vulnerable and say, I don't know. Would you mind if I go and speak to somebody else? And very few things in MSK are so urgent. Like, apart from like someone spurting blood from an artery or someone clutching their chest and falling to the ground, there are very few things that can't wait half an hour for a phone call, or wait for the person next door to finish with their patient so you can knock on the door and go in. So yes, it's urgent and emergency, but like, take a step back and recognize that you've got a bit of breathing space. That was the message we were trying to get across there. And the whole like first question, second question, third question, the problem solving, the thought process behind it is far more important than the answer of yes or no. So that was the main thing we wanted to get across. And to answer your question, the difficulty I found that Tom, I think, has solved personally, I think he's a really good science communicator, is to get that across in non-threatening, plain language. Even though we're writing to clinicians, there is an expectation. Like, if you see a person who's a nurse in clinic, the worst thing you can do is go, oh, well, you know what I'm talking about because you're a nurse, don't. They might be a wound care nurse, no idea about MSK, or a GP. We give them the deference of, oh, well, you're in the field, you know what I'm talking about. No, let's just level the playing field here. Sorry if I'm talking to you like, a child, and you this, and this is too simple. It's not my intention, but I just need to be clear with my language. How do we get that across in a book? That was the main thing.
And it's now 2 years old, that book?
Pretty much, not far off.
Change anything?
I wouldn't do it again. No, that's not fair. That's not fair. I don't know. Maybe I would. I think I wouldn't, if I'm honest with you. I think I'm really proud of it. I'm really proud of the work Tom's done in running with it, marketing it, putting it out there. We've had some really nice feedback. We had some naysayers before it was written or before it was published as to, why is this needed? And for me, it'd be a case, well, read it and tell me if it's needed or not. All the articles are out there and published, but are people reading them, and are people understanding them? This is a plain language summary. So I think I wouldn't change how we've gone about it. I think I'm pretty proud of it.
Is there anything apart from the book? I'll put your social media on the info as well. Anything else I need to plug or say?
No, I don't have anything to sell, like beyond the books there. But if people want me to come and talk to their institute or their organization or whatever, that is something I have done and continue to do every now and again. But I'm not chasing after it. It's not something that I'm desperate to do this. I'm not like trying to kick down doors and say, like, listen to me speak. If you want me to speak and I've got the time, and you think I've got the ability to communicate the thing you want communicated, then I'm happy to do it. I think sometimes an external voice to your organization helps, because I talk to people within my organization all the time, but people can get tired of your voice. So like, it's nice to have it's nice to have another voice. But yeah, I'm not actively seeking anything, but if you want me to talk, get in touch and I'll see what I can accommodate.
Grand. Sorted. Easy. Thanks, Rob, especially for a particularly difficult topic, and for your patter. Anything else to say before we let people go?
I'm going to ask you a question.
Cool.
I was asked this question on Tuesday, and my answer surprised and almost disgusted the individual.
Okay, go on then.
Black Sabbath.
Yeah.
Aussie or Dio?
So my answer is that I only know Black Sabbath as with Ozzy. So that is my answer.
Okay.
But if someone was to expose me to Dio and I was to prefer that version, I would be happily change my mind.
Okay. Very
I'm
diplomatic.
not tied to Ozzy and Black Sabbath. Which did you pick? I presume you must
Dio.
pick the Dio version.
Yeah.
Yes.
So again, I sort of expanded upon like what's your criteria for this? Like in terms of iconic, Ozzy, because Sabbath and Ozzy, they go much like you said, you're not invested in the band so much, but so your exposure has always been Ozzy.
Yeah.
And Ozzy certainly has his merits, his vocals and stuff like that. But Ronnie James Dio as a vocalist, pretty much unrivaled by most of the people out there. Like tremendous, tremendous voice. Stage presence, curation of, stage shows and stuff like that. They're just tremendous. And so from a pure talent perspective, I went Ronnie James Dio.
I'll tell you what, I'll end it with this. Ozzy solo or Ozzy and Black Sabbath?
Oh, Ozzy solo introduced me to Zach Wilde.
Yeah.
And so I have a special place in my heart for Ozzy solo. And I think personally, I prefer the album Heaven and Hell. So Dio, that's a Dio album with Sabbath. So I'd probably go Ozzy solo.
There you go. Cool. We'll leave it at that. Thank you, Rob. And
Cheers, mate.
thank you.